Good morning, everyone, and welcome to today's lecture on eating disorders and psychiatric and medical perspectives. Our goal is to deepen your understanding of how eating disorders operate not only as a psychiatric condition, but as a complex medical syndrome involving the brain, body, and environment. As physician associates, you'll often be among the first clinicians to identify these illnesses. Sometimes when patient presents with what appears to be benign medical complaint, fatigue, dizziness, or GI upset, but beneath those symptoms can lie a life-threatening psychiatric illness. Training objectives. By the end of this lecture, you should be able to identify the major DSM-5 eating disorder categories and their distinguishing features, understand the neurobiological and psychiatric underpinnings of these conditions, conduct an appropriate diagnostic and medical workup, implement psychotherapeutic and pharmacological strategies tailored to each disorder, and recognize when hospitalization is indicated and coordinate multidisciplinary care. Eating disorders are not lifestyle choices. They are serious biologically rooted psychiatric illnesses with some of the highest mortality rates in psychiatry. In severe cases of anorexia nervosa, mortality can reach up to 20%, often due to cardiac complications or suicide. These disorders combine biological vulnerability, psychological distress, and socio-cultural pressures. Our challenge as clinicians is to treat not just the physical symptoms, but the internal world of control, perfectionism, and the fear that sustains the disorder. DSM-5 diagnostic overview lets us briefly review the main diagnostic categories. Anorexia nervosa, characterized by food restriction, intense fear of weight gain, and body image distortion. Common findings include lanugo, bradycardia, hypotension, and amenorrhea. Bulimia nervosa, binge eating with compensatory behaviors, vomiting, laxatives, fasting, or excessive exercise. Look for parotid enlargement, dental erosion, and Russell sign. Binge eating disorder, binging episodes without purging, emotional dysregulation, and depression are central. ARFID, ARFID, is avoidant restrictive food intake disorder, not about body image, but about fear, sensory sensitivity, or trauma. OSFED, which is OSFED, other specified feeding or eating disorder, partial criteria presentation such as atypical anorexia or purging disorder. Each diagnosis requires a unique therapeutic strategy balancing medical stabilization and psychiatric treatment. The etiology and neurobiology, these are neurobiological disorders with genetic heritability estimated at 50 to 70%. Serotonin dysregulation contributes to anxiety and appetite suppression. Dopamine dysfunction underlies altered reward sensitivity. Patients may derive anxiety rather than pleasure from eating. Norepinephrine and GABA imbalances affect stress response and emotional control. Neuroimaging abnormalities in the insula, amygdala, and anterior cingulate cortex, all key in reward, fear, and interoception. These findings remind us the brain of an eating disorder patient is literally processes food differently. How do you assess and work this patient up? When you evaluate a patient, take a biopsychosocial approach. Ask about restriction, binge, and purge patterns. Explore rituals, exercise compulsion, and emotional triggers. Screening tools like the SCOFF questionnaire, SCOFF, the EAT 26 scale, and BEDS 7 are excellent in primary or outpatient settings. Physical exams check vital signs for bradycardia, erosion, and parotid swelling. Labs include electrolytes, phosphate, magnesium, ECG for QTC prolongation. The hospital criteria is a heart rate less than 40, a systolic blood pressure of less than 90, and a weight less than 75% ideal or severe electrolyte imbalance. Remember, these criteria are life-saving and non-negotiable. How do you do psychotherapy with these patients? Psychotherapy remains the most evidence-based treatment approach. The right therapy depends on the diagnosis and the patient stage. CBT-E, which is enhanced cognitive behavioral therapy, gold standard for bulimia and binge eating, focuses on distorted beliefs about food, weight, and body image. Family-based therapy, first line for adolescents with anorexia, empowers parents in refeeding process. DBT, dialectical behavioral therapy, useful in binge purge subtypes, where impulsivity and emotional dysregulation dominate. Psychodynamic or trauma-informed therapy, reserved for chronic or trauma-based presentations addressing attachment wounds and identity issues. The key is flexibility. Meet the patient where they are psychologically are, and always balance insight work with emotional safety. What about pharmacotherapy? Pharmacotherapy, like anorexia nervosa, SSRIs, are very ineffective until nutritional restoration. The brain simply lacks serotonin substrate. Begin after stabilization of the eating disorder. Olanzapine or quetiapine can help reduce obsessive thoughts and promote weight gain. Mirtazapine may be used for appetite and sleep, but avoid benzodiazepines long term. Bulimia nervosa. Fluoxetine is the only FDA-approved treatment, reduces binge purge frequency by 50%. Topiramate and other SSRIs can be used off-label, but avoid bupropion. The seizure risk in purging disorders is significant. Binge eating disorders. Vyvanse is FDA approved. SSRIs, topiramate, and GLP-1 agonists may support control anxiety, but monitor for misuse. ARFID. Mirtazapine and cyproheptadine, don't forget that one, also known as periactin, are highly effective for appetite stimulation and anxiety reduction. SSRIs can target underlying anxiety. Low-dose antipsychotics may help in severe sensory rigidity and managing comorbidities. So, in this case, eating disorders rarely occur alone. Depression, OCD, anxiety, ADHD, and trauma frequently coexist. When treating these conditions, avoid bupropion or in any purging disorder. SSRIs require adequate nutrition for efficacy. And lissamphetamine, otherwise known as Vyvanse, may serve dual purpose in bed with ADHD. Always reassess cardiac and metabolic risk when combining psychotropic. Medical management and refeeding. Refeeding syndrome is one of the most dangerous complications in anorexia. Start nutrition at 1,200 kilocalories a day, increasing slowly to by 200 to 300 kilocalories. Monitor phosphate, potassium, and magnesium daily for 72 hours. Administer thiamine before refeeding to prevent Wernicke's encephalopathy. Ongoing follow-up includes DEXA scans for bone density, ECGs for QTC, and coordinated psychiatric care for relapse prevention. This is also involving a multidisciplinary approach. No single provider can manage an eating disorder alone. Physician associates, physicians oversee labs, vitals, data, and coordinate care. Psychiatrist leads pharmacological management, and a psychotherapy delivers CBT, DBT, or trauma work. And a registered dietitian rebuilds nutrition and meal structure. Family reinforces recovery and accountability. The PA often serves as the hub, ensuring all moving parts communicate effectively. Here's an example of a clinical case. Let's look at a 22-year-old female with BMI of 16.5, bradycardia and hypokalemia. This patient requires immediate hospitalization for cardiac monitoring and electrolyte correction. Once medically stable, begin olanzapine 2.5 milligrams QHS and coordinate CBT with a specialized therapist and dietitian. And the key teaching point, you must feed the brain before you treat it psychiatrically. No antidepressant will work without a nutritional substrate. Key pearls for PAs. Always screen for suicidality and self-harm. Never use bupropion for any purging disorder. Olanzapine has strongest evidence for anorexia weight restoration. And fluoxetine, 60 milligrams, only FDA approved for SSRI for bulimia. Vyvanse, only FDA approved for binge eating disorder. And coordinate care actively. Eating disorder treatment is not a siloed medicine. Eating disorders are not fundamentally about food. They're about disorders of identity, control, and emotional regulation. As a physician associate, your role is to detect early, stabilize medically, and engage patients with compassion and persistence. Remember, early recognition and integrated care saves lives. So the next time you see a patient with an unexplained GI issue or menstrual irregularities, ask yourself, what's beneath the surface of this symptom? That single question can change the trajectory of their life. Thank you. Until next time.